Daktari, what's your interpretation here?
Eric, you send this gentleman back on leave. I don't know why he digs up these proverbs. They begin as neighbors and end up as mice. Well, I'll assume my interpretation would be that we've got a relationship which is kind of symbiotic as neighbors. And if they end up as mice, I'm assuming mice are vermin, so some sort of parasitic relationship, so something that morphs from a symbiotic to a parasitic relationship. That would be my interpretation.
Yeah. Sasa weka science chini. Tell us, bwana, in language.
Oh, in normal language.
Okay, after they've been symbiotic,
And parasitic.
parasitic. Okay, the parasites have been symbiotic. We've got that one now.
And they are vermin.
So it's a relationship that's mutually beneficial at the beginning, but tends to be more one-sided, where one person is taking advantage of the other. That's what I'd interpret it as.
You know, the beauty of a proverb is always this, the diversity of interpretations. And it opens your eyes to how people will look and then see. But I love your interpretation of it. It's wonderful.
Yep.
In a very brief sentence, you've actually summarized it quite well. Thank you.
And it basically just speaks to the issue.
Yeah.
Yes.
Goes straight into it. It's like, just a doctor operating and I'm a cutter. I mean, this mambo mingi. Mambo mingi, you forget it. We need to get to the cancer.
Yeah.
He's the chairman of the National Cancer Institute. What is that institute?
The National Cancer Institute is an organization that was set up in 2012 under the Cancer Prevention and Control Act. It is mainly charged with matters to do with treatment, prevention, and control of cancer in Kenya. And it provides more leadership, oversight, and coordination of activities in this cancer space. So that is the main mandate of the National Cancer Institute. Of course, it does that under the Ministry of Health, so it's not. It's done with definitely the oversight of the Ministry of Health, which is the parent ministry, because that's the one that again sets the overall legislation that runs everything cancer in this country. But that's it. That in essence is what the National Cancer Institute is about. So it works together with many other organizations. Any organizations that are involved, for example, like in today's topic, you've got hospices and palliative care organizations. It is in charge of promoting awareness to do with cancer in terms of ways in which we can prevent cancer. We coordinate the treatment, make sure that the quality of treatment that cancer patients are getting in this country is up to standard. We make sure that cancer patients, for example, are not discriminated against in terms of their rights and civil liberties. That's a major concern. We see the quality of treatment that they get, and anything to do with the welfare of cancer patients in general falls within our mandate. So in general, that is it. And then also aspects to do with education, to do with research, also promoting that. And more importantly, also one of the most important things is that the cancer registry, so that we've got data that is local, that is relevant, that helps decision-making in terms of cancer, whether it's in terms of prevention, control, or treatment. So that in general is the mandate of the National Cancer Institute.
Cancer registry. This is a conversation that has been there for a while. Like, do we actually have the statistics of cancer patients and the types of cancers in Kenya? Have we been able to get this now as an institute?
Well, it is work in progress. And one of the challenges that I think there is in this country is that we have got to be able, for you to be able to get that cancer registry, number one, we are going to have proper diagnosis. That diagnosis has to be made, and then the information also has to be relayed with the specific facilities where people are going. So you find, for example, there's some people, for example, who have cancer which are not even diagnosed.
Yeah.
So those are going to fall through the cracks. So eventually, this is one of the reasons why it was important for us to have a system where we can be able to have all this data in one huge database and have that transmitted centrally, and it'll help in decision making. So that is work in progress.
Okay. Into the conversation for today, which is hospice and palliative care. What's that?
Well, palliative care is an area where it's an interdisciplinary care approach. In general, it is for patients who have got serious illnesses, chronic illnesses, and those in general that are life-limiting or life-threatening. So it's an interdisciplinary approach so that we are able to provide, first of all, the emphasis is usually in hospice and palliative care, is to optimize the quality of life. Quality of life, optimize quality of life, and let me just add, secondly, also, other than optimizing the quality of life, is to reduce health-related suffering. So those are two major facets of hospice and palliative care. The reason I talk about chronic illness, when you've got a malaria for 2-3 days, usually the psychological impacts are minimal. You get treated and you get well. When you've got any illness that is chronic, and especially one that is life-threatening, then now you go into a realm where we're talking about more psychological effects, and we're talking about something affecting not just you, it affects your family, it affects your ability to earn, it affects your well-being.
Yeah.
So you can see in that space, it is more multidisciplinary because now we're involving all manner of caregivers. And that's the difference between hospice and between palliative care and the other realms. Now, palliative care and hospice care, slight differences, but palliative care in general, they will say, is something that you can be given concurrently with curative treatment. For example, you are on cancer treatment, but there are certain symptoms and so on that still need to be relieved. You can get palliation at the same time. Hospice care in general in the past was now when they're saying, I don't like this term, but people used to say a terminal illness, when you've got a terminal illness. I don't like that term, terminal illness, because first, I think all of us are terminal. All right, so the fact is all of us are going to die. We just don't know when and how. It's just that with people, when you've got certain illnesses, you see the end as sooner rather than later. However, it also, in terms of caregiving, it became a problem because when you've got somebody and you labeled as having terminal illness, the impression is there's no more that can be done. And then people were taken to hospices, more like to be dumped there. In terms of there's nothing more we can do for you. Unfortunately, most of the time, again, it was an issue of when the resources become depleted in the regular healthcare system, then people say, now we can move you to this.
hospice.
All right? Whereas the truth is, there's still a lot can be done even when illnesses cannot be cured. And again, there's a lot of ethical issues around this because you must remember that also as in medical ethics, there's this aspect about people are very clear about beneficence. We are supposed to do good, but we're also supposed to do no harm. And there are times when actually doctors don't know also when to stop. And there are times when it is right just to stop with the curative care because you know we cannot make the endurance of the cure for the illness more painful than endurance of the same. So there are times when, and we mean well, but there are times when actually we need to stop. And especially even when you've got people who've got illnesses, sometimes you've got people in this country who are on, for example, some chemotherapy, and you sometimes look and you wonder, where is this going? Because quite clearly, it is so far gone. And sometimes you deprive the people of the opportunity to be able to spend their last days in terms of doing things that are more useful, in terms of spending time with family, being at home, you're exposing them to side effects. So that's another ethical issue which I think needs to be addressed because we need to make sure that the people who get therapy are actually people who are going to clinically benefit from it.
So you didn't define the difference between hospice and palliative care.
Well,
Hospice is institutionalized though.
Actually, both of them can be, even hospice care. Hospice care is actually more, hospice care can be institutional in terms of inpatient care or home-based care, and palliative care. The only difference is the timing of when you do it. But in general, the words, there's a lot of overlap.
They're interchangeable.
But a hospice, in terms, hospice is actually more of an institution. And in Kenya, we've got only outpatient hospices. But now we have palliative care units, remember, that are mainly in facilities, especially the public hospitals. So we've got a lot of overlap in terms of that. But for me, if you were to ask me, especially at the end of life, if we can have a system where we have people taken care of within their homes, it would be better. But that's one of the things that we want. It's got a lot of things to do with how we devolve that care, how we provide healthcare financing so that we make sure people are able to be comfortable at home as opposed to being in hospitals. One of the things that I was very vocal about in my previous life as the chair of SHA is that I was very keen that we should get palliative care and home-based care and pay for it so that people can be able to stay at home. Because if you provide care only within hospitals, what you incentivize happens. Everybody's going to move from home and come to the hospital because that's where the care is being paid for. So what we need to do is facilitate the ability for patients to be taken care of and be comfortable within their homes.
Yeah. Because I think you touched on what I was going to, bring on board, because that's the conversation. There's one thing to create these institutions, access it. There's another thing to afford it. And I'm glad you touched on it because the conversation now, and you saw what happened, I think, at the beginning of this week, I suppose, if not last week, the kind of pain and agony that a number of patients were going through based on the transition we had. from NHIF to SHIF or SHA, and the aspect of ensuring some of these particular services that you're talking about. I mean, I speak for the layman, for the person in the grassroots, who is really thinking, where is my place in all this palliative care? How far does it go? I know you've mentioned public hospitals, but I know places where it's really deep grassroots. It's a reserve, and sometimes even the hospitals, clinics there don't operate over the weekends. I don't know if you've seen such scenarios.
Yes.
How far are you extending this discussion of today? How far are we going, and how far have we reached, really?
Healthcare financing is a very core pillar if we're going to be able to succeed in providing the care that people need. Healthcare financing is crucial because cancer is one of those illnesses. Being a chronic illness, we have seen it time and again.
Yeah.
You start with somebody who is unwell. First of all, you've got all those costs, direct and indirect costs related to the care.
Yeah.
Then first thing that happens, there's imperfect income smoothing. And by that I mean, you're not able to sustain your level of income. Because first, most of the time, you're out of a job. If you're somebody who's informally employed, then what happens? You're not going to work, you're not getting paid. If you're a hawker and you usually walk around, if you're in hospital or you're unwell, you're not getting paid. Then the next thing you come to is saving. Any savings that you have disappear. Then after that, you go to the next level again. Now you start disposing of assets. Then next you go to the level of now you're borrowing and so on. So that's why healthcare financing here in this space is crucial, because if you're going to be able to access care, leave alone having the facilities might be there.
Yeah.
If you can't afford them, you can't access those services.
Yep.
And that's why it was extremely important, even as we tried to transform our healthcare system and our healthcare financing system, it was crucial. It is painful to see the kind of things that we saw a short while ago. That should never have happened, if you were to ask me. It's unfortunate, but it is what it is.
The discussion around cancer in this country has increased exponentially. Why is that so?
Sorry, the discussion there?
Around cancer, about cancer.
Yes. Cancer, what happens is, I think, in general, if you ask me, cancer, if you look at how cancer develops, first of all, cancer can only develop in cells that are dividing. That's why you don't have cancer of the hair and of the nails. So the more you have cells dividing, the more likelihood you'll have cancer in those cells. That's why you've got certain cells which we call, if it's dead tissue, you can't have cancer there. Those that are slowly dividing, cancer will be rare. For example, you rarely hear about cancer of the heart, for example, or of the lens, or of the neurons, leave alone brain, but the brain, the neurons themselves don't divide, because there's less likelihood of them to form cancer because they're not dividing. Then those cells that are dividing very fast, like those in the gastrointestinal tract, those things because they keep being sloughing off and being replaced. For example, scales in your skin and so on. Those are the areas where you get a lot of cancer. Breast, for example, in breast tissue, cervix and so on, those are the places where you get a lot of cancer. So in terms of cancer and its development, then you've got now, first of all, people have got predisposition. Some people, it's genetic, it's hereditary, that you can do nothing about, all right? Other than looking actively to prevent, detect early, and to be able to manage. But there are also other factors that are causing the increased incidence of cancer, things to do with our lifestyle. Smoking is a big no-no. Smoking and tobacco use is one thing that I've never had anything good about. I cannot say anything good. It can only do harm.
Doesn't keep you warm?
No.
Okay.
Okay. I've never had that one. But in terms of health effects, there's nothing. Smoking is just bad. And it just doesn't increase just the incidence of lung cancer. It predisposes to other forms of cancer as well. But these are now causing tissue damage. And when there's tissue damage, there's a tendency to repair. You're increasing the rate of multiplication. Again, you're predisposing yourself to cancer.
So do we have more incidences of cancer in this country? Or is it that we've become more adept, we are better at diagnosing and understanding it?
I think it's a combination of both. Our lifestyles have definitely contributed to the increased incidence of cancer as we get in touch with more what we call carcinogens, because we are ingesting them, we are smoking them. There's an aspect of pollution. There's also obesity in itself, which is also a risk factor for cancer in itself. So there are a lot of things. As we use more drugs and so on, I'm sure the incidents, those things contribute. But then again, the aspect of diagnosis. In the village, I'm sure in the past, there are a lot of people who used to pass away. I know in my village, there's a storm called Yamo, which is like a wind. They just say it's like a wind. Somebody just got this wind and died, I'm sure. A lot of those things were possibly cancer.
Or witchcraft.
So there are a lot of things that before were not diagnosed that we're diagnosing now.
Yeah.
So it's a combination of both. But the truth is, cancer is going to take center stage in terms of our healthcare system. And the truth is, again, a lot of the cancers are prevented. Eric can't stop laughing. There are a lot of cancers that we have that are preventable as well, because we have to limit these things. It could even up to be 4 out of 10 cancers. So those are the things that we need to do.
There are parts of this country that have been mentioned as having higher incidences than others. What is the predisposition? What is it that one looks for when you're saying that certain areas not are likely to, but already have that predisposition?
Well, it could be something to do with the environment. For example, it could be something to do with the diet, with their lifestyle. For example, things like for example, people who've got diets predominantly smoked food, smoked fish, and so on. Possibly those are things that are high risk in terms of esophageal cancer and so on. So it's got to do with environment. It could be something pollution. There could be some factory. There could be something in the environment that is causing increased risk of cancer. So there are a lot of components that it's a very complex space. But in general, suffice it to say that there are a lot of things that we can do as prevention, and one of the things that the National Cancer Institute that we have to do is to promote awareness in terms of being able to limit, and then prevention, early detection, because especially in a country which is resource constrained like ours, we cannot afford to be waiting and getting people when they're diagnosed late. We have to prevent those that we can. Those that we end up getting cancer, we have to diagnose them early and manage them accordingly.
The prevention story is a good one, Daktari. When it's told, it sounds really nice.
Yes.
But it's not just for cancer. When you talk about healthcare,
Yes.
it is argued, and argued correctly, that it ought to be the way. But that's where it begins and ends. We talk about it. How do you go about preventing or limiting the possibility of people actually acquiring cancer? What is it that you do? Early detection, yes, test. But having known the predisposition and the factors that contribute to it, what is it that needs to be done?
Awareness promotion, so that we promote healthy lifestyles. And people will get to know that, number one, these are the risks that we put ourselves to if we engage in certain behaviors like I've talked about, the smoking, excessive alcohol consumption. We talked about some viral infections, for example, which are predispose people to cancer, for example, HPV, EBV, and so on. We need to be able to look for ways of being able to control that, diagnose it early, and controlling our environment. So if there's an aspect to do with pollution, we have to be able to control it. Let us make sure that foods that we're having in this country, for example, the level of toxins, carcinogens, we've got a lot of pesticides possibly in our environment. So those are the things that we need to be able to manage. But more importantly, when it comes to screening, and this is where I'm saying in terms of deploying the resources, the cancers that are most common, let's first of all start with the ones that are most common and do something substantive about them. It's breast cancer, cervical cancer, prostate cancer, esophageal cancer. Those are things that we should be able to focus on and concentrate and look for ways of being able to diagnose early.
Yeah.
There are some that are more difficult. For example, the gastrointestinal cancers, those ones that are alimentary canal. Usually, most of the time, you have to take a scope and look in. It's a bit more of an invasive procedure. But for colorectal cancer, for example, if we can be able to see blood in the stool, we've got certain tests we can do for prostates. For men, we can be able to do PSAs. For breast cancer screening, we can be able to do that cervical cancer screening. If we're able to start with those, because by and large, those are almost up to 50% of the cancers we deal with in this country. So that would be the area where we want to deploy our resources, where we're getting best bang for our buck.
That's true. Let's take a break at 27 minutes to 9. Our guest this morning is Dr. Timothy Oluenyi, Health Friday conversation ahead of tomorrow. Tomorrow is what's the day tomorrow? What's it called globally?
World Hospices and Palliative Care Day.
World Hospices and Palliative
And it's on the 2nd
Day.
October of every year.
Yes. On second.
Second Saturday of every
2nd October.
Sorry, the second Saturday in October of every year.
Oh, great.
Second Saturday of October in every year.
Yes.
Tomorrow, the 12th, is the second Saturday of October, and that's why we're having this conversation today, just to understand hospice and palliative care. We'll be back shortly. Siti, please tell Dr. about loop. First of all, define loop. What is the loop?
Well, if you were to define loop comprehensively, it's a process where you move forward and you engage in diverse activities. But in that process, you go back to the beginning, meaning the end ties with the beginning. Now, that's a loop. So nothing is lost. Now, the loop that we are referring to here is an app that does precisely that. You know, every time you think money, you think fintech if you're in the 21st century, or you think bank, or you think SACCO. Now, the Loop app does more for you in this day and age than anything you may have encountered. One, it helps you manage your money in a way that you previously couldn't have. Like that building you're putting up in your rural home, there's this fundi who keeps calling you. If you know the progress, you can actually time the payments, time it. So the payment actually goes to him at the designated time and you don't have to worry. Whether it is weekly, whether it is monthly, whether it is every 2 days, done. If it's a question of determining how it is you want to save or what it is you want to buy, that app enables you to do all that. But it doesn't stop there. The app enables you to actually even get an overdraft. It even allows you to even get a loan. Yes, it does. All the factors considered. It's not as though you download the app and you get a loan immediately. That one.
Terms and conditions.
Terms and conditions
will apply, yes.
So you get app by downloading it on the Play Store, Google Play Store, Apple App Store. Go there, find Loop. It's orange in color and it has an L, and you download it, register, sign up. It's very, very easy. While on the Play Store and App Store, you can also download the latest, most improved Naivas app. Naivas saves you money. And as you get there, then you can shop from Naivas across the country. But also, the bigger thing is if you're in Nairobi and you want to get a 24 hours Naivas, you can get these ones: Naivas Westlands, Airport View, Ronald Ngala, Moi Avenue, Development House, Kangara, which are 24 hours. 2 new ones. Where are they?
Oh, they're in Utawala.
Right.
And uko kwa Nyama, Kamakis.
Very good.
Wait, bypass.
Kamakis. Naivas, Kamakis, and Naivas Utawala are now 24 hours. Keep it here for more. It's 2049.
Money on your rising electricity bill with